It's with gratitude that I would like to introduce Joe. JOE GIACINO, which I had to have him tell me his name phonetically, is a professor of physical medicine and rehabilitation at Harvard Medical School and the director of rehabilitation, neuropsychology, and the Disorders of Consciousness program and the neurorehabilitation laboratory at Spaulding Rehabilitation Hospital. He also holds appointments as a neuropsychologist in the Department of Psychiatry at Massachusetts General Hospital, the adjunct professor in the Rehabilitation Sciences doctoral program at Mass General, and teaches neuroethics at the Harvard Medical Center for Bioethics. He has research that focuses on developing more precise neurodiagnostic procedures, clinical outcome assessment measures, and therapies for persons with severely acquired brain injury. He serves as the principal and co-principal investigator on multiple federally funded multi-center grants, including the Spaulding Harvard Traumatic Brain Injury Model System, Transforming Research and Clinical Knowledge in TBI, TBI Endpoint Development, and Central Thalamic Stimulation for TBI. Joe is a past president of the American Congress Rehabilitation Medicine, and he led expert panels that developed the minimally conscious state case definition and 2018 practice guideline updates on disorders of consciousness. So I'm excited to have him here. This is a great opportunity. And without further ado, Joe, thank you.
Thank you, Catherine. And thank you all for your interest in this topic, first of all. Let me just get set up here. So this is going to be interesting because I'm going to be operating off my laptop and the slides. That means I have to use two hands in both hemispheres. But in a delirious state, that doesn't usually work. So we'll see how this goes. All right, give me one more second to get set. Okay. So thank you again for your interest. I mean, this is an area that is, if you know anything about it, is fraught with confusion, misunderstanding, misdiagnosis, etc. So, you know, I'm not far from retirement, and before I get there, I'd like to feel that we have moved the needle, and I think we have in many ways. The research in this area is accelerating exponentially. And I'm going to attempt in the next, whatever it is, maybe 75 minutes or so, give you the whole lay of the landscape in my view of what the state of the science is in this area. And I have to update this talk multiple times a year because things are moving that quickly. So it'll be a ton of material. I'm going to go relatively quickly through it. You guys are here for the day, so we'll have plenty of time to talk about what I present here and then the other material that I'll be talking about. But let me just start, first of all, by thanking Catherine and Lawrence, who couldn't make it today, for all their help in getting this set up. This was a 2-year-plus effort, I think, to get this to happen. It finally did. So thank you for that. And then I would be, let's make sure this works. I would be remiss not to thank Dr. Manley, who really is the one who made this possible. He has an abiding interest in this area as a neurosurgeon, and but beyond that, his interest in doing the right thing is unmatched. There are a lot of I'll say inappropriate decisions that get made on this population, largely out of lack of knowledge, not ill will, but lack of knowledge. And Jeff has done a lot to sort of spread the word that we need to be thinking about these patients, this population in a different way. And I hope at the end of this talk, you'll see that. He is beyond a world-class neurosurgeon, one of the most effective leaders on the planet. And he is because of two things. He has high IQ, intelligence quotient, but I think more importantly has high EQ, emotional quotient. He is very aware of where he's at when he's interacting with other people, and keeps that in check. And you put those two things together and you get a really good leader. Underneath the hood and all the luster, though, he's just a good old boy. This is what everyone loves about Jeff. So I wish he was here. He can't be because he's doing a talk himself, literally, I think, at the same time as I am. But I just wanted to give a special thanks and shout out to him. My disclosures. I'm going to skip this slide because people who are joining online, this won't be relevant because they're not staying for the rest of the day, but we'll come back to this. This is the plan for the whole day for those who are going to be here for the whole day. But in the interest of time, I'm going to get to the meat of it. So I'm going to present, as I mentioned, an overview of the state of the science in this area and best practices for management of persons with disorders of consciousness. I'm going to cover a lot of ground. So I'll move fairly quickly through these slides. I'll slow down on some of them, but it'll be a bit of a whirlwind tour. I'll go over first definitions and distinguishing features of the major disorders of consciousness, and then undergirding this whole talk are really the 2018 practice guidelines that were sponsored by the American Academy of Neurology, the American Congress of Rehabilitation Medicine, and I'm seeing Dr. Hempel in the back, applause, and the National Institute on Disability, Independent Living, and Rehabilitation Research. This was a fairly unique joint effort. So you had a federal agency partnering with two organizations that had never partnered before, the ACRM and the American Academy of Neurology, to put these guidelines together. This took about 5 years to get it done. So underneath what you're going to see are the practice guidelines. And they're going to cover diagnosis, prognosis, natural history of recovery, and treatment. All right, so let's talk about what disorders we'll be talking about. So these are the major disorders of consciousness: coma, sustained pathologic unconsciousness in which the eyes remain continuously closed. I'm not going to get into this now, but I'll tell you that definition is already under threat, I'll say. There's some evidence that patients can be in coma with eyes open. Now, I think this is a problem for the field because it will be hugely difficult to differentiate somebody in coma from somebody in vegetative state, and that matters in terms of trajectory of recovery. So again, I'm not going to get into it, but I think we should still think about coma most typically being an eyes closed state. The eyes never open in coma. In the vegetative state, there's complete absence of any behavioral evidence of awareness, and I'm stressing behavioral evidence because you'll see shortly that there are people who are conscious with no behavioral evidence of awareness, which you may know about already, of self and environment. Eyes are open because the arousal system is back online. There's preserved sleep-wake cycles if you do an EEG. So this is the vegetative state. The next step up the ladder is the minimally conscious state. Consciousness is severely altered in this state, but there's minimal but definitive evidence of behaviors indicative of conscious awareness. The problem with minimally conscious state, or for us, is that it fluctuates. That's a hallmark feature. So behavioral signs of consciousness are present 1 minute, 1 day, 1 week, and not the next. And so it's this sort of floating state that makes it very difficult to get a handle on. It has recently been subdivided into two substates, if you will, minimally conscious state plus and minus. So the plus means that these are individuals whose evidence of conscious awareness includes language function. So they're either able to communicate verbally or gesturally or able to follow commands. Those in MCS minus have other signs, behavioral signs of conscious awareness, but no evidence, at least observable, of language function. And I may come back to this later. This is important because it looks like there's a prognostic difference between these two conditions. So if you're MCS plus, and that's recognized early, so the point is it's important to recognize it early, outcome is typically more favorable than if you're MCS minus. And then the highest rung on the DoC, for disorders of consciousness ladder, is the post-traumatic confusional state, or if it's not traumatic, the acute confusional state. And we might not think about the confused patient as having a disorder of consciousness, but really it fits. I mean, it is the upper rung on the ladder. So these are individuals who have reduced ability to focus or sustain attention. They're disoriented to time and place. They can't encode new information, so they have rapid loss of any new information. And again, a defining feature, like minimally conscious state, symptom fluctuation. So the brain can't maintain activation of conjoint network activity well enough to keep in a steady state. And that's why if you work with patients who are confused, 1 minute they're fine, they're with you. The next minute they're in left field, they're out of it. And that goes up and down, just as in minimally conscious state we see that fluctuation, but it's at a lower level. So these are the 4 disorders that we're really talking about. I'm not going to go through this table in any detail, but it shows the behavioral features associated with each disorder of consciousness. The red boxes highlight the distinguishing features associated with each condition. And then the purple arrow indicates the progressive increase in the number and complexity of the behaviors observed as you go up this continuum. Why? Because, again, the brain is able to access more of the distributed networks needed to engage behavior as it improves, or the other way around, less able to do so the more severe the injury. Oh, I'm sorry. See, I screwed up. I didn't give you the boxes. I did it on my side and didn't do it for you. So those are the distinguishing features. Okay, I said before that this talk is really going to be underpinned by the 2018 practice guidelines. This is a look at the 2 papers that were published in Neurology and then concurrently published in the Archives of Physical Medicine and Rehabilitation. The one on the left was the systematic review of the world literature that was done first to summarize what we know, and then from those data were then synthesized and became the practice guidelines, which you see on the right. So again, this will be the substance or the foundation for what you're going to see. I want to point out, you see this box on the bottom, level of obligation. So practice guidelines are based on evidence. So the strongest evidence mandates compliance with the recommendation, while weaker evidence suggests that one should consider using a particular technique or assessment strategy. So there are really 4 levels. A level A recommendation means that you really must be using it. The evidence is pretty overwhelmingly in favor of doing or not doing something, because it can go in both directions. A level B recommendation, you should be considering it. Again, evidence is pretty strong without a lot of opposing evidence. A level C is an option. There's no evidence that this thing, whatever it is harmful, but there's ambiguous evidence as to whether it helps. And then a level U is that thing that you're doing for assessment or treatment. There's not enough evidence to make a decision either way. So if you're doing it, you have to be transparent in those you're working with that we don't really know. There's not evidence either way. All right. So let's go into diagnostic assessment. And the first thing I have to mention about this is that this is a huge problem. These are the 3 papers that are cited the most frequently in the literature that look at how accurate we are in diagnosing. Really what I'm talking about is consciousness. So what these rates are saying is that about 40% of the time, or 4 people in 10, we say that person's not conscious when in fact they retain conscious awareness. And we know that from a number of different studies that have taken different strategies to that were the sort of reference standard. In some cases, these data are based on a team that got together, right, as we do every day, do their evaluations and decide whether the person's conscious or not, against somebody else going in with a standardized assessment approach, finding evidence when the team did not. In other cases, these rates are related to functional imaging or functional EEG studies that determine consciousness based on, and I'll come back to this later, evidence in the signature of activity in the brain that we can say with high confidence is indicative of conscious processing, but we don't see that at the bedside. But the point is, in medicine, where would these misdiagnosis rates be tolerated? Not many places. Now, that's not just because we don't do a good job or we're not well trained. It goes back to what I said before as well. These states fluctuate. So if you are not following people, you do a one-off exam and you happen to catch the person at the wrong time and they're in a down state, you're going to get the wrong diagnosis. They're just down for that moment. That's a point I'll come back to as well later. Why do we have, I've touched on some of this already. So why do we have such high error rates? There's a very strong tendency still across disciplines to rely on qualitative assessment at the bedside. I have my PET exam. I do it. I'm using my eyeballs to assess whether a response occurred, and it's my subjective opinion. But the next guy who comes in and sees that same patient has a different exam, has a different set of rules as to what counts as a response. That's part of the problem. That's where standardized assessment helps us. We don't pay enough attention to the baseline arousal level of the patient before we start the examination. I'll show you some case studies demonstrating this. So if you have somebody who's clearly under-aroused, or maybe even asleep before you start your exam and you start right in, that person's is going to be in too down-regulated a state to show you their sort of maximum level of cognitive function. So you have to do something at the front end of the examination to maximize or optimize the brain state, improve the arousal level in order to allow that person to be prepared to respond. And we don't typically do that. I mentioned the fluctuation in state, insufficient behavioral sampling. On an ICU, there's a lot of pressure to see a lot of people in a short amount of time. So there's no blame here, but it's a problem because to really do a very good assessment of a patient with disturbance in consciousness, it takes a lot of time. We don't sample enough behaviors. When you have a severe brain injury, many different systems of the brain are damaged. So if you happen to ask the patient to execute a response in a system that is damaged, it has nothing to do with consciousness. They can't execute it because the system's not allowing them to engage that particular output, if you will. So you have to sample more behaviors, meaning more brain networks and more systems in the body that are intact. And that takes a lot of time. So I have some cases that I'll demonstrate that or illustrate that point. And then, of course, we have the problem of unrecognized or occult medical complications and then sedating agents, medications that make this difficult as well. The consequences of misdiagnosis are dire. Misinterpreting one's level of consciousness. I have a bioethicist colleague from Cornell who has written about this and talked about it as being the most significant assault to a human being is to not know that they're conscious, that they're aware, that they're there. Leads to an inaccurate prognostic counseling, inappropriate decision-making about goals of care and treatment. I'll show you some data around that. And then, of course, if we give incorrect or inappropriate prognoses and recommendations, family and caregiver distress goes up. Okay, so let me take you through some of the I'm just selecting some of the key guidelines. These are the ones I think that are most important for everyday practice, and we'll dig into these a little bit. So recommendation 2A from the guidelines says clinicians should use standardized neurobehavioral assessment measures that have been shown to be valid and reliable. The American Congress of Rehab Medicine, which I'll show you in a minute, did its own evidence-based review of the literature and basically rank ordered the ones that are strongest in terms of their psychometric characteristics. And I'll show you what those are. So these standardized techniques should be used to improve diagnostic accuracy. This is a level B recommendation, which is a should. So you should use standardized assessment approaches. The rationale for this, I said before, here's a look at that paper that summarized these 6 scales listed here on the left are the ones that were recommended for use in clinical practice excuse me, by the ACRM based on the number of psychometric characteristics that they met. So they're the most robust. There were 13 scales that are designed for disorders of consciousness that were in this review. Only 6 of them were recommended for practice, and the reason the coma recovery scale revised is bolded, it's the only scale that came out with minor reservations. The other 5 were recommended for clinical practice, use in clinical practice, but had at least one major reservation. One of the reasons that I think the CRSR did well, and by the way, you know, that's my horse in the race, but I had no influence on the results of that effort. But one of the reasons that it did perform well is there's been a lot of study on the psychometric characteristics. The scale is now almost 30 years old. It blows my mind that the scale is about 30 years old now. It's been improved over time, but there's a lot of study by many groups looking at how it performs. And then, you know, we will do a deep dive for those in the room who can stay into the CRSR later in the day. So I want to show you something, and bear with me because some of you may fade out at this point. I hope you don't, but this is, for me, one of the most exciting things that's happened in a while, and it is that, so I have a colleague at the University of Colorado, Jen Weaver, who is a measurement expert, and she has developed a coma recovery scale recovery ruler using rash analysis. It's an advanced statistical technique that's based on item response theory. I won't get into the details around that. But what rash analysis does, it recalibrates raw scores. So the CRSR has a point range from 0 to 23. Those are raw scores. It recalibrates those raw scores into units that are called logits, and puts them on a common scale with equal intervals. So let me tell you what I mean. So if you look at the CRSR raw scores on the bottom here, 0 to 23. That's how the CRSR is set up currently. And then you look at the logit scale below here. It goes from -7 to +7, and 0 is in the middle here. You notice that these units are equal interval. Notice the different spacing of the raw scores on the CRSR. So, and what I should tell you also is that easy means the items on the CRSR that are the least complex will fall on this end of the spectrum, and the ones that are most complex, like functional communication, will fall on this side of the scale. And what we can do is plot somebody's scores with the CRSR across each of the 6 subscales, and that's what you see here. But here's the point I want to make, if I can get my 2 hemispheres to work. Okay. So you'll notice that a 1-point difference on the CRSR does not always equate to a 1 unit difference on the logit scale. So here, going from a 1 to a 2 is about the same as 1 unit on the logit scale. But if you go to the middle of the CRSR scale, so persons gets a score between 8 and 12, a 1 unit difference is equivalent to 5 different scores. There's a 5-point spread. What that means is those point differences from 8 to 9 to 10 to 11 to 12 are not that meaningful. They're not that meaningful because any of those scores kind of is around the same level of function. So if a person is moving and you're looking at change, which is one of the things we do with the CRSR, you want to know if when they go from an 8 to a 10, is that a meaningful change or is it not a meaningful change? So this suggests that it may not be because all those scores sort of mean the same thing. But when you change, on the Logit scale, it's equal interval. So it's the same amount of difficulty to get from each, move along that continuum from the -7 to +7. I hope that's starting to make some sense. And you can think about that scale. That's the consciousness scale. So behaviors that are the easiest, which would be reflexes, would be on this side of the scale. Sorry. Be on this side of the scale, and again, the most difficult on this side. Now, the other thing that I think this allows us to do is if we have, so somebody gets a score of 17, total score on the 17 on the coma recovery scale. We can draw this vertical line through the 17 across the scales. And what that vertical line is telling us is for somebody at that level of function, here's what scores you should expect to see for that individual across the 6 subscales. The 6 subscales of the CRSR relate to the different cortical networks in the brain. We have the language network, we have the motor network, we have the visual perceptual network, and the arousal network. The idea is if consciousness is suppressed and then starts to come back, and that's the main problem, we should see all those networks coming back around the same time. But we don't see that often. Why? Because with brain injury, particularly traumatic brain injury, the brain is damaged in multiple locations. Also, there is also suppression in consciousness. But what this tells us, for example, is a person with a score of 17. These are the scores we should expect to see on each of those 6 subscales. So it's a 1 on communication. Actually, I can't see it here, so let me see if I have the notes here. You may be able to see it better. So in this case, a 2 on the oral motor verbal subscale, a 2 on the arousal subscale, a 5 on the motor subscale, a 4 on the visual, a 3 on auditory, and a 1 on communication. That's what these scores are. They all line up here. This is important because if we do a CRSR and we find a patient who has a score on one of the subscales hanging out here, or in particular, I should say, on this side, way off this line, that's telling us there's a subsystem in the brain that's probably damaged, specifically, structurally damaged, that's causing this function to not, to not be accessible. Because it should be around where the other behaviors are, but it's not. So it tells us we should be looking for lesions that account for loss of behavior in that network as opposed to the other networks which are sort of in alignment. So we can come back to this point because it's somewhat complex, but the point is this allows us, this sort of rescaling system allows us to compare changes in performance in the same patient over time and determine what a meaningful change is. It allows us to compare multiple patients head to head and look at their trajectory. So you could say this person's recovering faster than that person, not relying on raw scores, but relying on these Logit score changes. And then it allows us, again, to predict where somebody should be functioning across all 6 subscales, again, reflecting the 3 or the 4 networks of the brain. And if they're not where they should be, that suggests that there's a subsystem in the brain that's more that may be structurally damaged, specifically damaged, and is not going to come around in the same way in terms of the trajectory of recovery as the others. Okay, let me move on. Second important diagnostic recommendation. Serial standardized neurobehavioral assessment should be performed. How frequently you do it depends on a number of things, and it's not prescribed, but what is prescribed here is, again, as I alluded to before, one-off evaluations don't work in this population. You're probably going to get the wrong diagnosis. You're probably going to miss consciousness when it's present. And this is a level B recommendation, so meaning pretty good evidence. And here's the key study that drove this, which is a very good study that was conducted by a group in Belgium, the Coma Science Group. So what this says, essentially, is that if you do a single single examination, and this is using a standardized scale like the CRSR. If you do one single CRSR examination, the probability that you miss consciousness on that one exam is 36%. That's pretty damn high, if you ask me. But if you do 5 exams with the CRSR, that error rate goes down to 5%. Makes sense, because I talked about the fact that these patients' level of consciousness fluctuates. So you have 5 chances to capture that person at an upstate, right? And you're going to have a greater chance then of seeing conscious awareness because you gave the person a better chance to demonstrate it. And beyond this, it holds for both minimally conscious state and vegetative state. So you can see that what these bars are showing is the same thing, that you get a lower misdiagnosis rate by doing multiple examinations, regardless of whether the patient is in vegetative state or minimally conscious state. Okay, let's move on to 2C. Okay, I alluded to this before. A major error I think gets made in clinical practice is to ignore the resting level of arousal of the patient before doing the examination. Patients are often down-regulated. The brain, after severe brain injury, is idling at a low state. It's not ready to respond, typically. So what we want to do is to see if we can maximize that arousal level, again, to help that brain be prepared to respond to some sort of sensory stimulus. So here's the recommendation. Attempt to increase arousal before doing the evaluation, anytime you suspect that its arousal is low. And I'm going to, in the afternoon, show you how to do this, show you a technique that uses deep pressure, which is the one that we've been using for 30 years. It's part of the Coma Recovery Scale revised protocol. I mean, we recognized this problem early, and in the 3 decades, I still think it's one of the most important things to do in the examination before doing any kind of assessment of command following, visual function, motor function, et cetera. So let's see what else I have here to tell you about that. So I'm going to, because we're going to come back to that, I'm not going to say much more about that now, except I will tell you, and you'll see this in the afternoon, that there's a study that's been published now that used EEG to look at arousal responses with the deep pressure protocol that we use. And in fact, it does upregulate the brain. So what we see in terms of arousal behaviors when we use this technique, eye-opening, longer eye-opening, increased movement, et cetera, the behavioral features are associated with changes in the EEG and indicating increased alertness. Now you have a patient ready to respond when you start to do things like ask them to squeeze your hand or blink their eyes or something. Okay, we need to identify and treat conditions that might confound accurate diagnosis of a person with DOC before we establish that diagnosis. That's a level B recommendation. There's pretty good evidence to support this, and it's based on a number of studies, including this one that was carried out by John White, which looked at the frequency with which persons with DOC have specific medical complications. The top 4 to be on the lookout for are here: hypotonia, hypertonia, urinary tract infections, sleep disturbance, and agitation. Any of those can complicate the examination. These are less frequent: pneumonia, storming or paroxysmal sympathetic hyperactivity, and hydrocephalus. They're less frequent, but they're obviously much more serious and often lead to either, if the person's in a rehab setting, rehospitalization, or if they're in the acute care hospital, it's going to slow that person's recovery down. So, but the point here is these are the ones to look out for, to be on the alert for, to recognize early, because they're going to confound consciousness. Okay. 2E. This is probably the most controversial of the recommendations. In situations in which there's continued ambiguity regarding whether there is evidence of conscious awareness, even after doing serial standardized behavioral assessment, or where you know there are confounders to the examination. Clinicians now, for the first time when these guidelines were released in 2018, are now free to use functional neuroimaging and functional electrophysiologic techniques to go looking for what is referred to as covert consciousness. So evidence of consciousness that we can't see at the bedside. In the past, those techniques, functional MRI, functional EEG, were really experimental, but now they're part of clinical practice if a particular facility has the capacity to perform these tests. Not the vast majority do not, but the point is this is sanctioned for use in clinical practice because there's enough evidence to support their consideration. Notice it's a level C, which means it's an option. You're not mandated to do this because the evidence isn't strong enough, but it should be, it can be, I slipped up there, it can be considered. So the condition that we're talking about here is called, I called it in general covert consciousness we can't see, but the technical term is cognitive motor dissociation, CMD. So the idea is that preserved consciousness or preserved cognition is detached from what we can see in terms of motor function. No speech, no movement in response to prompts to speak, move, etc. The specific definition is when you put the person in the scanner, and what happens here is you take the individual, you put them in, let's use the functional neuroimaging protocol. You put them in the scanner, and then you expose that person to different types of stimuli in the scanner. And in CMD, we use what are called active stimuli. So the person is asked, for example, to imagine doing something while they're in the scanner. Imagine opening and closing your hand. Imagine playing tennis, these sorts of things. What we know is that individuals, healthy individuals, who go into the scanner, are asked to do those things, have a signature of activity in the brain that is very recognizable and distinct from other kinds of signals that the brain may throw up. So the point is, you can tell with very high certainty if somebody is imagining doing a task just by looking at their fMRI profile, or if you're doing it with EEG, just by looking at the pattern of activity on the EEG. So this was originally demonstrated all the way back in 2006 by Adrian Owen, and then was taken another step up by Martin Monti, who turned this, what it is, it's covert command following, right? So you're in the scanner, you tell the person, I want you to imagine playing tennis. If the person is capable of understanding that and they begin imagining playing tennis, we pick up that signal with the fMRI or the EEG because it's distinguishable from all the other brain activity, and we can recognize it because it matches up what a healthy person's brain looks like doing the same thing. What Martin Monti did, he turned that into a communication system. So he said, okay, now what we're going to do, so I have to tell you one more thing. So playing tennis, I didn't just make that up. That was the original protocol. What Adrian Owen's group did was to do two things. He said, now I want you to imagine walking around the rooms of your house while you're in the scanner. And so that drives a different signal of brain activity. So there's a tennis playing signature, there's a walking around your house signature, and they're completely distinguishable. You can tell with 100% accuracy which of those two things the person is doing in the scanner, just by looking at the fMRI profile or the EEG profile. Then what Martin Monti did, he said, let's turn it into a communication system. You guys are speech pathologists, so if you haven't, maybe you know this already, but if you haven't, it's really relevant. He said, okay, we'll ask somebody a question, and then we'll tell them, if your answer is yes, imagine playing tennis. If your answer is no, imagine walking around the rooms of your house. And ran this protocol on 54 patients in vegetative state or minimally conscious state, and found that 1 of 54 people followed correctly answered 5 of 6 questions using that technique. This is, again, a person who was not even known to be conscious. Not only were they conscious, they also found in that study 5 other people who were conscious. They couldn't do the yes-no signaling, but were following the instructions to walk around the rooms of the house and play tennis. They just couldn't turn it into a communication system. One person did do that. So suggesting that that's a much higher level of function if I'm communicating, right, just by mentally thinking about things. And that person has no behavioral signs of consciousness on the bedside examination, right? That's alarming. Okay. So now we have this our toolbox is larger. We can do standardized behavioral assessment. We can do functional MRI. We can do functional EEG. We can ask the family what they think. So the one thing that I'm concerned about, and I'm just going to put this out there, is that we will have, let's use those 4 tools. We're going to have a lot of permutations of what we might get if we did all 4 tools. So patients 1 or 2, this is hypothetical, but patients 1 and 2 have consistent findings across all 4 types of examination. So in patient 1, they're positive on all. We can have high confidence that those results, whether they're activating or they're performing the task that the test is looking for, and they're doing it across the board. So we can have high confidence and believe that result. Patient 2, we can also have very high confidence because they're all negative. But what happens, oh, see, I'm screwing up again. I gotta be pressing this button, not that button. Oh. All right, what happens when we have a scenario like 3 and 4 where the results are mixed? Which results do we believe? We don't have a weighting system that says, oh, fMRI is definitely better than EEG. Oh, the standardized behavioral assessment is better than the functional imaging or FEEG. And now we have to sit down with the family. We have 4 results that are mixed. What do we do with that? That's a bit of a conundrum. I haven't solved that, except to tell the family that this could happen. If we want to go ahead and do these tests, just know this might happen, and I might not be able to tell you what I think is the case with high enough confidence for you to to walk away thinking you know the answer. That's the only way we can deal with this right now. Okay. Diagnostic assessment in DOC is complex. Getting it right requires a high level of knowledge, skill, time to do these examinations, and neurodiagnostic technologies like the ones I talked about. I'm not going to go through this, but this is the decision-making algorithm that drives the examination. We have to ask essentially all of these questions in the examination to get to one of these final diagnoses. Time-consuming, complicated, but if we're going to get it right, we have to do it. All right, let me move on to prognosis. So recommendation 3 from the guidelines says, when discussing prognosis with caregivers of persons with disorders of consciousness, during the first, I didn't mention this before, let me take a step back. These guidelines, these practice recommendations are designed primarily for people who are 28 days or more post-injury. Why is that? This was a joint venture between the ACRM and the American Academy of Neurology. Yes, I get it from the ACRM side. These are rehabilitation people. They work in the post-acute space, but neurologists work in the acute space as well. Why did this group decide to stick with 28 days? And the reason for that is we wanted to clear coma, because coma is associated with a very wide range of outcomes, right? People can be in coma for a brief period of time and walk out of the hospital, basically. They can also be in coma and then transition to vegetative state and never regain consciousness. And we also don't have really any evidence to go on to suggest what a typical course of recovery or what the natural history of recovery from coma is. We do for vegetative state, we do for minimally conscious state. So it takes typically 2 to 4 weeks at the outlying period to emerge from coma. So the whole premise was to make this task more specific, we did not want to include people in coma. So you have to know that going into this. That's the rationale for why this is about people who are 28 days post. That said, many of these recommendations, you can surmise, are absolutely applicable to people who are less than 28 days. This is the only one that is specific to people who are less than 28 days post-injury. And it is that clinicians should avoid statements that suggest these patients have a universally poor prognosis. Level A recommendation, must. The highest recommendation, the strongest evidence. Where does that come from? So here is a list of all of the predictors of outcome that studies in the patients with disorders of consciousness have looked at. Those are on the left column. And what you see here are this column is prognostic factors associated with better prognosis, but what's most important is what's the level of confidence we can have in that predictor. And that's based on the evidence. So you have, you may see that there's this particular index is a significant predictor of favorable outcome. But it's not applicable to the individual patient because the confidence limits around it are very wide, meaning that the range of performance for that predictor is not tight enough to say anything very specific. So it turns out that's the case for every predictor we have. So at best, we can have moderate confidence in some predictors, low confidence in most predictors, both on predictors that predict better prognosis as well as predictors that are associated with poor prognosis. So the point is, we can't have a lot of confidence in our predictors in this population right now. So that's part of the driver for why we should not be definitive in the very early stages that somebody is destined to have a poor prognosis. There are certainly people who will. There are certainly some findings that suggest that, but if we're really looking at the evidence to drive this, we don't have any evidence that says definitively that that person's outcome is going to be poor. Let me tie this to these data. This is data on withdrawal of life-sustaining treatment. Keeping in mind what I just said, that we don't have reliable early prognostic indicators. These data show the frequency and the timing of withdrawing life-sustaining treatment in persons with severe TBI. And they cut across age brackets, by the way. So it doesn't matter if you're young or you're old, these data hold up pretty much the same. You probably can't see the numbers very well, but what I can tell you is that the window for that decision is typically 72 hours. So the first 72 hours is when that decision gets made most often. And it is the most common cause of death after TBI. So we do it between 60 to 70% of the time. And that decision gets made within 72 hours, despite having access to reliable prognostic indicators. That's a disconnect in my view. So given those data, so keep that in the back of your mind. Moving on to recommendation number 7, given the frequency of recovery of consciousness after 3 months in patients who are unconscious due to non-traumatic causes, and after 12 months in patients who are unconscious due to traumatic injury. Why 3 and 12? Those were the standards that we were using before the 28 guidelines. If you were in a vegetative state for more than 3 months, you were thought to have no chance of recovery. That was considered a permanent vegetative state. We would advise the family, that's it, done, recovery finished. If you had a traumatic brain injury and you were in a vegetative state, we deferred that to 12 months. But at that point, we said, really no hope for further recovery at this point. It's been 12 months, no recovery of consciousness, consider it permanent. Well, it turns out both were wrong. And because of that, we don't use this term permanent vegetative state anymore. We've turned it into chronic vegetative state when it lasts longer than the time periods you see here. Why? Well, here's the data to support this. These are data from the traumatic brain injury model systems. They follow people for life. This is a group of patients who had disorders of consciousness that were followed over the course of 5 years. The definition of unconsciousness here was not following commands. So you see here on the x-axis the percentage that recovered consciousness during rehab by 1 year, by 2 years, by 5 years, and you see these numbers. So these are those who survive. A lot of people do die early on from natural causes, but we don't even know what that number really is because of the withdrawal of life-sustaining treatment problem. But the survivors, look, this is the recovery curve that model systems found over 5 years in, I think the N is here, in 337 people who had follow-up through 5 years. This is a study from Anna Astranio's group in Italy. She looked at patients in vegetative state, no consciousness, who were at least 6 months. On average, they were 11 months in that state. Remember that vegetative state, 3 months if it's non-traumatic, it's permanent, 12 months if it's traumatic. So they were the average was 11 months, and she followed them out for more than 2 years. And what you see here in blue is the percentage with TBI that recovered consciousness and the time frame, and the time frames they did it in. So after 12 months, between 12 and 18, 17, these are actually the raw numbers. 33% recovered consciousness after TBI, 9% after non-TBI, 12% after non-TBI, and then another 12% not only recovered consciousness, but got to the point where they could communicate reliably after these time points. And these numbers continue to go out with smaller, but people are recovering consciousness well after these time frames that we thought indicated permanence. A study by Doug Katz, a neurologist in Braintree, Massachusetts. And basically what you see here on the right, the index here, is levels of function. So this dark blue color, vegetative state, going all the way up to this teal color, people who are back able to communicate and back able to participate in the community independently. So what you see here at 1 month, you got a lot of orange and blue, which means these patients are functioning at a level in which consciousness is disturbed. If you follow them out past 12 months to 4 years, look at the shrinkage and how much of this red or orange color and blue color and this color we have. It's not very much. And look at what's happened. Those who survived, a large proportion of them are functioning independently in the community. Okay, so let me continue down this path, looking at natural history of recovery, focusing on what we know about recovery during inpatient rehabilitation over the course of the first year and between 1 and 10 years post-injury now. We didn't have these studies that went out 10 years until the last 5 years. Okay, so I'm going to tell you about this paper, which was my group did. And we're talking here about recovery in individuals who get to inpatient rehab with a disorder of consciousness. We have really surprising little data on behavioral recovery. What's the trajectory of recovery of specific behaviors? So what we did is we used the coma recovery scale in about 197 patients, actually, with disorders of consciousness who were involved in the placebo arm of a clinical trial. So they didn't get any treatment. So they were a good cohort to look at their recovery over time because they were very carefully followed over a period of 6 weeks. And what we looked at our outcomes were the proportion of the sample who showed the target behavior we were interested in. We selected the highest level behavior on each of the 6 subscales of the CRSR, and we asked how many people recovered it over a 6-week period. We looked at the total number of the highest behaviors recovered out of the 6. We looked at how many how many people emerged from MCS, meaning they could communicate reliably or they could use objects in a functional manner. And we looked at their median disability rating scale score against the number of behaviors that they recovered. So what do we find? So you see here in the bar graph on the left, these are percentages. So it's the percentage showing each of these behaviors: consistent command following, ability to recognize objects, ability to use objects in a functional manner, ability to speak intelligibly, ability to communicate reliably, ability to sustain attention. So the blue is at baseline, and you see that most of these have no blue because it was 0% of these patients could do these things when we started. And then there were a few patients who had these behaviors at the outset. But what you're seeing here is the percentages who regained these behaviors after a 6-week period. It's high, right? 29 to 42% recover these behaviors in a 6-week period in inpatient rehab. They're not showing these behaviors when they're in the ICU. They're not showing these behaviors when they get to rehab. But they do after that. Not only that, but look at how many they show. So about 20% of this group of nearly 100 ended up recovering all 6 of these high-level behaviors within that 6-week period. And then if you add, I don't know if I have this here. No, I don't. If the orange is people who got 5 out of 6. So the point is, and this doesn't surprise me, that if you gain one of these highest level behaviors, you're likely to gain more because these behaviors are very complex. They require a lot of distributed network activity to be functioning again. So I think if you can engage that much brain to do something like follow commands consistently, you can engage the brain also to do these other high-level behaviors because there's enough preservation of brain function to do these other things. So it doesn't surprise me that if you got one back, you got a bunch back. For each behavior recovered in this study, the disability rating scale score improved by about 2 points, so that there was a 12-point spread between patients who recovered all 6 behaviors and those who recovered none. Why do these findings matter? Sorry, I got to catch up on my end here. Critical prognostic decisions, we just talked about, typically made within 72 hours of injury before there's recovery of command following speech or other conscious behaviors. But what we're seeing is that despite remaining in the vegetative or minimally conscious state in this study, for a median of 47 days, 20% of this cohort recovered all 6 of these target behaviors within this 6-week observation period. Persistent vegetative state, that is a vegetative state that lasts for at least 1 month, is viewed as a dire condition. People look at that and say, no hope for recovery. 20% of people in vegetative state at enrollment in that study were consistently following commands by the end of the 6-week interval. Family members tell us that recovery of reliable communication is their number 1 most important thing, what they're looking for most often. In this study, 1 in 5 patients who remained in traumatic vegetative or minimally conscious state for at least 4 weeks, there's that 28-day period, subsequently recovered the ability to communicate in a reliable manner, verbalize intelligibly, or follow commands. This study also looked at recovery of consciousness and function during inpatient rehab. Led by Bob Kowalski, it's a TBI model system study, followed 7,547 patients who had disturbance in consciousness when they were initially evaluated in the emergency department. The top right panel here shows a snapshot of the progression of recovery of consciousness from the ED to rehab discharge. So during the acute hospitalization, 57% of these patients had disturbance in consciousness. They were not following commands. Then, by discharge from rehab, that number dropped to 12%. Oh, sorry. By admission dropped to 12%. By discharge, it's down to 2%. The bottom right panel indicates that while persons with DOC, the yellow line, had lower functional status on the functional independence measure, a standardized measure of self-care activities, et cetera, at the start of inpatient rehab, so that line there, that group experienced greater absolute improvement in level of function during inpatient rehab than the group that did not have disturbance in consciousness. So the group that did improved by 43 points on the FIM, the group that did not by 37. So the point is, they're changing a lot. They're still more disabled, more compromised, but to suggest that they're static is just flatly wrong. And then in that cohort, 40% were partially or fully independent in those behaviors on the functional independent measure by the time of discharge. We think that protracted disturbance in consciousness, and again, that's 28 days, is considered an ominous prognostic sign. It is for some people, but the point is, for a substantial percentage, it is not. Here, 80% of people who had disturbance in consciousness on admission to rehab recovered consciousness by discharge. We think lack of early improvement predicts lack of subsequent improvement. That's wrong. Patients with versus without DOC in that study had more improvement overall than those who did not have disturbance in consciousness. I told you before, the most frequent cause of death after TBI is withdrawal of life-sustaining treatment, and that decision is made typically in 72 hours. Well, I mean, I think these data are starting to suggest very strongly that clinicians should be very cautious about suggesting a high probability of poor outcome and suggesting withdrawal of life-sustaining treatment within that first month. Let's go on to this study from Track TBI. This is the study that Jeff Manley leads. Mike McCrae and I led this study. Let me catch up on my end here. Sorry. It's a cross-sectional study, and what we looked at was functional outcome across the first year post-injury in patients who had moderate to severe TBI. So there were 362 patients enrolled in the Track TBI study with moderate to severe TBI who had outcome data out to 12 months. Primary outcome that we were looking at here was the Glasgow Outcome Scale Extended score. The way we score this is, in this study, we look at disability that was caused by injury to the brain plus any peripheral injury. So if you broke both of your legs, it was counted in the score. I tell you that because the GOSI gets scored very differently, one group, one hospital, one investigator to the other, but nobody reports how they scored it. And so you can't compare a GOSI score that rates disability due to brain injury only with a GOSI score that rates disability due to brain injury plus the peripheral injuries. They tell you different things. I'm telling you that this study included both, so you understand that. Then we had secondary outcomes, the disability rating scale, which is another global functional outcome measure, and then a bunch of symptom rating scales and cognitive performance tests. Okay. So based on the Glasgow Outcome Scale, we found that by 12 months post-injury, 52% of this sample recovered the ability to function independently at home for at least 8 hours a day. So that's half the sample. On the DRS, on the DRS, the disability rating scale, interested in the same thing, global outcome measure, but it assesses it differently. 19% had no disability at 12 months. And then another 14% had only mild disability on this measure. This 19, 20% figure keeps popping up, study after study. 1 in 5 people who look catastrophically injured at admission go on to recover functional independence if they survive. This number is not coincidentally 1 in 5. It can't be. Question?
I'm sorry to interrupt, Dr. Giacino. Sorry. Before you get too much further, the previous 2 studies that you mentioned, inpatient rehab, that is in acute hospital
So, good question. So that's in an inpatient rehabilitation hospital, an IRF, an inpatient rehab facility. I work at Spaulding Rehabilitation Hospital. My acute care center is Massachusetts General Hospital. So these are not, I think what you're asking, rehab happens in the acute setting, right? That's what you're getting at. You're trying to differentiate. Yeah, this is not rehab being performed during the acute stay. It's the patient's been referred, now in the inpatient rehab setting.
Got it. And then the same with and the previous two studies were all traumatic brain injury as well.
The previous two studies were all, yes, important point, if I didn't say that. Yeah, I hope the slide did. Yeah, yes. Yeah, no, I warned you. The other key finding in this TRACK TBI study is this one. So again, vegetative state, ominous. You don't want to hear that term because you think no chance for good recovery, or the first thought is likelihood of recovery of consciousness not very good if somebody enters that state. Well, it turns out that all but one of the surviving patients who were in vegetative state at 2 weeks had recovered consciousness by 12 months, but more importantly, 25% of that group was functionally independent by 12 months. Big difference of what's happening at 2 weeks versus 12 months. There's the one patient who did not. This is an area that's fraught with nihilism, right? I've made this point many different ways so far this morning. But the percentage of people we see with severe TBI and prolonged disturbance in consciousness in this particular study who had a favorable outcome or have a favorable outcome score on the GOSI quadruples from 2 weeks to 12 months. Trauma center specialists often overestimate the likelihood of poor outcome after moderate to severe TBI, which negatively biases early decision making. I think this is a function of context, that you don't get a chance when you're in this setting to see what's happening downstream, right? That's the point. Most moderate to severely injured traumatic brain injury survivors eventually regain functional independence. The vegetative state diagnosis generally reviewed as static, incompatible with subsequent functional recovery, but again, you saw in that study, the great majority of those who survived vegetative state recovered consciousness by a year, and 1 in 4 became independent by 12 months. What happens after a year? So this is a study, again, from the TBI model systems. Sorry, let me get to the right place. Followed patients with disorders of consciousness beyond 12 months post-injury. We don't often do that, right? It's very hard to do it in clinical practice, and even for research, it very rarely occurs. But I'm here to tell you that we have to do it because there's a different picture that emerges when we do. So the TBI model systems, as I mentioned before, follows people for life. So this paper by John White, led by John White, looked at outcome in this group between 2 and 5 years post-injury. And bottom line, let's just cut to the chase here. So the figure on the top left shows outcome across the first 5 years for those who recovered command following prior to rehab discharge. So they get to rehab, they're not following commands, but they recover commands during rehab. And then the panel on the bottom are people who get to rehab not following commands and are still not following commands when they leave rehab. What the lines are showing is the percentage of these two groups who recover, keep hitting the wrong thing, who recover these behaviors. These are pretty high-level self-care type behaviors, as well as cognitive behaviors. It's the percentage who regain them over the 5-year period. So the blue line is by discharge from rehab, red is 1 year, yellow or green is 2 years, and this purplish color is 5 years. So you can see from discharge to 1, 2, and 5 years, a dramatic increase in the percentage who have regained these behaviors. Even in those people who don't recover command following in rehab, if you follow them 1, 2, and 5 years down the line, we're still seeing between 20 and 40% of these individuals becoming independent in these activities shown on the bottom here. On the right panel, this is another study that followed patients out to 10 years post-injury. And the upshot here is that it used trajectory modeling to identify different subgroups of patients. It found 4 subgroups using modeling. 2 of those 4 subgroups continued to show functional improvement between 5 and 10 years post-injury, meaning regained the ability to be independent in these everyday activities somewhere between year 5 and year 10, two of these subgroups. These are the take-home points. Despite the inability to follow commands on admission to inpatient rehab, patients in this cohort, especially those who recovered command following during inpatient rehab, remember again, they weren't following commands at the acute site, became independent in these daily functional activities. Prior studies in this group have also suggested about 30% decline. This is data from the TBI model systems over somewhere between, they start to decline between the first 2 years, and this decline continues. Interestingly, and we don't really understand this yet, and maybe it's artifactual, we didn't see it in this population. You see it when you look at people who don't have disorders of consciousness, but had moderate severe TBI. About 1 out of 3 show decline in the measures that I'm using here. We didn't see it, interestingly, in this population. Not sure yet why, or if it's real. All right, last area. What do we know about treatment, and what should we be doing? So this is recommendation 1. Clinicians should refer patients with disorders of consciousness who have achieved medical stability to settings staffed by multidisciplinary rehab teams with specialized training to optimize diagnostic evaluation, prognostication, subsequent management, and medical monitoring. So this may seem, pretty rehab-oriented, right? I mean, you guys are mostly working in an acute setting, but it's not intended to be that way. The point is that, again, a lot of this action, this recovery is not happening in the early phases. It's delayed. The neurobiology of the condition is delayed. We just have a healthcare system that doesn't follow the neurobiology of the conditions. So this is not saying only rehab professionals can do this. That's not the way I want you to read this. But your team, if you're doing rehab in the acute setting, should be specialized because you're seeing these people, and all of this applies to you. The point is, you need specialized training. That's who should be doing the diagnosis. That's who should be doing the management, not somebody who has a sort of generalist background. There's just too much here, right? There's just too much going on. Why do we need it to be a specialist-driven area? I already talked about the fact that misdiagnosis is ridiculously high. These knowledge gaps that the general practitioner doesn't have are going to lead to overestimation or underestimation of prognosis. And there's some related evidence that cumulative mortality at 3 years post-discharge is actually significantly lower for people who went from the acute setting into inpatient rehab rather than inpatient setting to home or skilled nursing facilities. Interestingly, in that study that was published in JAMA, those who went home did better than those who went to the skilled nursing facility. Recommendation 14, clinicians caring for patients with traumatic vegetative and minimally conscious state between 4 and 16 weeks post-injury should, level B recommendation, prescribe amantadine. And the dosage is 100 to 200 milligrams twice a day to accelerate functional recovery and reduce the degree of disability in the early stages of recovery. But one has to be sure there are no medical contraindications for use of that drug. That's, again, a level B recommendation. It's based on this clinical trial that I led with others from the model system back in 2007. Let me just cut to the chase here. I won't read this. This is the rationale for why we thought amantadine would be a good drug to study. So here's what we found. The blue line, solid blue line, are the placebo group. They got a placebo preparation, no active medication. The red dashed line is the amantadine group. So they were followed on the disability rating scale. Again, that's, are you familiar with the DRS? Not, most are not. Okay. So if I am saying something that, just wave your hand at me because I want you to know what we're talking about. So the DRS has the Glasgow Coma Scale built into it. It's actually reverse scored because it's asking how much disability there is, not how much preserved function. And it has a number of other subscales that look at cognitive ability for toileting, grooming, dressing. It looks at level of independence, how much assistance one needs, and it looks at employability. So you get a total score, and then you get these subscale scores. So this used the DRS as the primary outcome measure. Patients were followed for 6 weeks. The first 4 was the active treatment. So if you got the drug, you got it for 4 weeks, and then we stopped it, and we had a 2-week washout period. So at the onset, at baseline, the two groups, the placebo group and the amantadine group, were indistinguishable on the DRS. No difference in their DRS scores. So we start the trial. And so what ends up happening is you can see pretty quickly these two lines start to part. So a lower score on the DRS means less disability, right? Because it's measuring disability. So the amount of disability is going down as indicated by the downward sloping line. And these two lines start splitting pretty quickly so that by the primary endpoint for this study, which was week 4, 1 month after treatment, now we have a significant difference in level of function between those two groups, the group on amantadine and the group that didn't get it. We stopped the drug at that point, and we asked, what do they look like 2 weeks later? So what's interesting is, look what happens to the amantadine group. They level off right after we stop the drug. So their recovery slows. And now, in fact, the placebo group's improving at a faster rate than the group that was previously treated with amantadine, interestingly. But the point is that once they get here at 6 weeks, they're no longer significantly different. Second line of evidence that amantadine works. Stop it and things slow down. Start it and they speed up. This is what percentage of people recovered the highest behavior on each coma recovery scale subscale. Highest behavior on each subscale of the coma recovery scale. I told you what those were before, right? Consistent command following, functional communication, functional object use, etc. The blue bar are those who got amantadine, the red, those on placebo. 2 things to note. One is the percentages are high in both groups. So even the group that got placebo, right, in red, these are pretty high percentages of the number of people who recovered. We saw this before. But the point I want to make here is if you got amantadine, your chances of recovering these behaviors are even higher. So the blue line is higher than the red line everywhere except, interestingly, for intelligible verbalization, which was very close, but very few people got it back in this time frame. But for every other behavior, more people regained it if they were on amantadine. But again, I don't want to lose sight of this other hidden finding, which is the placebo group is also doing well. Is recovering a lot of behavior.
What is the second column? I can't read it from here.
The second
set of columns that are so far down the graph.
So do you mean? So
Yes.
well, okay. So we have. So the blue bar is the percentage of people who got amantadine who recovered consistent command following. So that's 40%.
The second group, sorry, near the bottom, we just can't read the label. Object recognition. Say again?
Oh, you're talking about the labels?
The words.
I'm sorry. Consistent command following, object recognition, functional object use, intelligible verbalization, reliable communication, and focused attention. Again, those are the highest items on each subscale of the CRSR. We also took a look at, we had imaging data on these people, and we were interested in whether the structural findings on CT influenced response to amantadine. And overall, there was no significant difference based on lesion profile. So what we looked at, we had a score for lesion burden. So it turned out that people with the highest lesion burden did not have significantly different response or outcome relative to those with lower lesion burden. That said, I do want to point out, even though the findings weren't significant, We did see that this group, this was the group that had amantadine, but they had the highest lesion burden. They had the lowest response. So not surprisingly, lesion probably does matter. The lesion burden probably does matter in terms of the chance of responding to amantadine. But overall, it wasn't significant. What about adverse effects of amantadine? The take-home point here is that we found not even one single adverse effect that was significantly higher in the amantadine group, treated group. This is a safe drug to use. Other treatment considerations. Well, there are a bunch. People are willing to try a lot of things in a patient population for which A, there's only one treatment that's really recommended, and B, people are really compromised. So willing to try a lot of things. I'm going to just say a few words about what people are doing. So this slide, I'm not going to go through it in detail, but shows the various other interventions that are being used besides amantadine. So there's zolpidem, which is Ambien, the sleep drug. I'll talk about that in a minute a little bit more. Transcranial direct current stimulation, which is another form of electrical stimulation, along with deep brain stimulation. The difference is this is non-invasive, this is invasive, requiring surgery. Another non-invasive electrical technique is, non-invasive technique is transcranial magnetic stimulation. Another one that's being moved into clinical trials now is low-intensity focused ultrasound, interestingly, for this population. Transcutaneous vagal nerve stimulation. These are all being tried, but just know that there's no evidence base sufficient enough to support the use of any of these treatments up to this point, except for, again, amantadine. The one that comes closest is zolpidem, which I'll tell you about in a minute. I'm not going to get into this, but what's our approach to deciding what treatment to use? It's shotgun. It's trial and error. It shouldn't be. We need a conceptual model that guides decision making. My colleague Nico Schiff at Cornell and his group have been working out this so-called meso-circuit model for this purpose, to get a better sense of what neurobiological substrate should be targeted with what treatment. And so this is, I don't have time to get into this now, but he started to map this. So if you know that the circuit is damaged here, use this agent. But if it's there, use that agent. Or if you know something about the mechanism. So that's a much more sophisticated way to do this than to just try it. If it fails, we'll try that. Or try everything. And we see a ton of that, right? So let me say a few words about zolpidem. Do you guys use it here, Ambien, in DoC? You don't know? Okay. Not much in the acute setting. Okay. Interesting, because in my place, all the time. Yeah. So this is, the drug you use to fall asleep. But, so it makes a little kind of counterintuitive. Why would we take a drug to put you to sleep to wake somebody up? So it turns out some patients have a paradoxical response to this medication. It's a sedative hypnotic agent used to treat insomnia. But we see people becoming, a small percentage, I'll show you that in a minute, becoming more responsive if they get zolpidem. And this was discovered accidentally by a guy in South Africa who was using the drug for other things and noticed this finding, but it's now been reproduced. John White did a multi-center clinical trial looking at response to zolpidem. So this is the largest trial that's been done to date. 83 people in vegetative or minimally conscious state between 5 and 99 months post-injury. So it was a subacute to post-acute sample. And so here's the upshot. 5% of response rate. And this has been held up in smaller studies since then. Not many people have this response, but a few do. And those few who have it really have it. I mean, you can't miss it when it happens, because they go from being remarkably unresponsive or underresponsive to remarkably responsive when they get the drug, and then the effect typically fades out until they get the next dose. So what I'm showing you here from John's trial are 4 cases that were responders. 3 of them were traumatic, 1 was anoxic. They found no clinical predictors. They looked for clinical predictors of response, found none. But what you see here is, let's see, I have this. You see this so what's happening is these are patients getting monitored with the coma recovery scale. They get a score at baseline, then they get the drug, then they get another CRS, and then they get another CRS, and they get another CRS. So we're watching the trajectory of their performance on the CRSR post-drug, pre and post-drug. So what you see in these 4 cases is at about an hour after getting the drug, there's this inflection in CRSR performance that's pretty unmistakable in each case. And then as you get out 2 to 3 hours, the performance drops again. So they get this boost, they get this boost, and they can't sustain it. But it tells us there is the capacity to recruit these subsystems in the brain that can perform better than they do at rest if they have this boost. Our job is to kind of figure out, and I'm speaking figuratively here, figure out how we can sustain this boost in this population. Transcranial direct current stimulation, not used that often, but is beginning to make its way into clinical practice now. What TDCS does is it either increases or decreases neuronal excitability in the brain. Sometimes there's too much excitability. We want to quiet it. It's interfering with function. Other times there's not enough activation or excitability, and we want to facilitate it. We want to boost it. So TDCS can do both. It can either quiet or ramp up. And so it's been used for patients with DoC. Aurora Thibault has published the most on this. She's from the Belgian group, Coma Science group. This is probably the best trial that is out there, where they did 20-minute session of TDCS over 5 consecutive days, small sample, 16 people in minimally conscious state. So there were no patients in vegetative state in this, all minimally conscious. And then the panel on the right shows their changes in the CRSR total score for those in the active TDCS condition in the gray boxes, and then in the sham condition. So you can fake TDCS, and that's what they did here. So that's the boxes in the white. And it looks at their performance over the days 5 to 12. The black lines in the boxes are the median change scores on the CRSR, and then the boxes are the upper and lower limits of the response. And then the bottom right, panel shows the evolution of the median CRS total score from baseline to day 12. So while there was no significant effect of TDCS on the CRSR subscale scores, the individual subscale scores, there was significant improvement in the total score from day 5 to 12 in the TDCS treated group, not in the sham group. So some evidence that TDCS may boost function in this patient population. And then lastly, I want to tell you about deep brain stimulation. This is the study that our group published in 2007. It was a single case, part of a larger clinical trial. It was the first case we did. We implanted electrodes in this patient's brain. You can see them here going down into the thalamus, specifically the central lateral nucleus of the thalamus. This was a bilateral implantation procedure. You can see the scan showing the trajectories for the electrodes going into the thalamus. And this patient was 6.5 years post-injury when he came into the trial. I had seen him in inpatient rehab when he was very early, post-injury. But he left, and when he left, he was MCS minus. He had some conscious behaviors, but no language, and was totally dependent, so MCS minus, very low functioning. Then he went to a nursing home for 6+ years, and we got this trial going, and we opened recruitment, and his family contacted and said, we want to be in the study. We brought him back into the hospital. When he was brought back, he was so debilitated physically, we couldn't even take him to surgery. He needed, I think, more than a month before we could get him physically strong enough to go through the surgical procedure. We got to that point, and I should tell you, so he was showing some MCS level behaviors, but he hardly ever did it. Very infrequent, not enough to be functionally meaningful when he came in. So what we were interested in was actually getting the few things he could do. And by the way, one of the things he could do, he could say words, but he hardly ever said them. And they were almost always a single word, but they were well articulated. There was no aphasia, there was no dysarthria. When he said a word, you understood it completely. But he hardly ever said words. And then the same thing, he would follow commands, but very inconsistently. So none of it was functionally meaningful. So we were asking, could we increase the frequency of these high-level behaviors that he was capable of, but hardly ever did, using deep brain stimulation? So what you see here in this graph are his scores on the CRSR on the different subscales. These are not the subscales. These are specific behaviors we pulled off the subscales because we thought these were his best chances of improving on these behaviors, because we saw evidence of these behaviors. But what I can tell you is that before we did the DBS, so this is the off period, all of these behaviors were low level. So no speech, only he could vocalize, but he couldn't say words, at least on every baseline exam we did. He couldn't sustain it, he rarely ever could sustain attention when we were prompting him to do things. He most of the time just kept his eyes open, but a lot of the times his eyes were closed even though he was awake. He had evidence of automatic movement, but never showed us any evidence of functional object use. And a few times he showed ability to manipulate an object. That would be things like being able to hold a cup, not use it, but he could hold it in his hand. So then we do the surgery here. And then we turn the DBS on. And so what you see here, right after we turn the DBS on, he has this step change in his scores across these three scales. So now he goes from essentially not speaking to frequently saying words when he's prompted to say them. I clocked him. I had him, in one case, say the first 16 words of the Pledge of Allegiance. Now, he had never done anything remotely like that before. He spent a lot of his time, I mentioned, with his eyes closed, even though he was awake. So post-DBS, his eyes were awake, his eyes were open. And not only that, but now he's sustaining attention, because what this is basically telling us is when we prompt him to do something, he does it most of the time. These were simple commands, but he wasn't doing it. He would do nothing. You tell him to do something, he wouldn't do anything. Now he's responding. And then automatic movements, which are things like scratching face, holding a handrail, turn into multiple instances of functional object use. Cup goes to the mouth, hairbrush to the head, sort of thing. So, DBS, I think, is a promising treatment. We have a ways to go. Our group is right now we have a new paper in review, not in DOC, but in patients with severe TBI who got DBS. So I'm hoping that within the next literally couple months at the most, we'll have more to report on this. 15, clinicians should counsel families about the limitations of existing evidence concerning treatment effectiveness and the potential risks and harms. Again, the evidence isn't there for all those treatments except for amantadine. We use them all the time. We should be transparent about that. And we should also make sure families know that it's really impossible in most cases for us to discern whether improvements we see after starting a treatment, especially with traumatic brain injury, are due to the treatment or due to spontaneous recovery. I showed you a ton of evidence showing how the natural history of recovery after TBI is typically one of change, of improvement. So when we start a med or start a new intervention and we see improvement, it's very hard in clinical practice to determine whether that's the spontaneous recovery or that's the treatment. We can try stopping the treatment to see if it slows down, but it's very hard to do that in the clinical setting. So we need to be, again, transparent about this as well. When discussing non-validated treatments, which accounts for most of them, we should talk, I think the key point here is we need to talk about risks of doing these treatments, and we need to say something about the degree of uncertainty that surrounds them. So we can stave off false hopes that might otherwise crop up. It's not to say we shouldn't do them, but we should provide context when we do them. All right, so that was your whirlwind tour. What can we conclude? Diagnostic accuracy can be optimized by doing serial, systematic, standardized evaluations, maximizing arousal level, trying to identify occult factors that can mask conscious awareness, supplementing behavioral assessment with functional imaging and electrophysiologic studies if they're available and when indicated, not necessarily on everybody. Prognostic accuracy can be improved by getting the diagnosis right. So I didn't show you that, but it turns out that if you can identify somebody in minimally conscious state and differentiate that person from someone who's unconscious very early on, that early MCS diagnosis, particularly for traumatic brain injury, predicts a significantly more favorable outcome at 12 months than the person who's not an MCS. So get the diagnosis right. Don't miss, detect consciousness when it's present, or at least do your best to do that for that reason. Awareness of the confidence limits around outcome predictors and models is extremely important, and we need to be transparent about it. We need to recognize that severe impairment in the first 2 weeks post-injury is definitely not a definitive marker of unfavorable long-term outcome. And when we're considering treatment, we need to be thinking about the neurobiological substrate underlying or mediating consciousness. Hopefully we'll get to the point where that's automated to some extent. It's not yet. I have hope that the effort that Dr. Hempel is leading from the Curing Coma campaign will make some serious headways there. This is a very robust effort. I hope all of you guys are part of the Curing Coma campaign effort. But I think that effort is poised to move us very much in this direction. And then we need to recognize that only amantadine has sufficient evidence to support routine use. And then, again, we need to disclose our uncertainty when we are treating somebody to family and other caregivers. Acknowledgements of a lot of people who I alluded to and whose work really has influenced mine along the way. And we're done.